You're listening to the lecture on management of patients with complications from heart disease. During this section, you should be able to identify the etiology, pathophysiology, and clinical manifestations of heart failure, describe the management of patients with heart failure, use the nursing process as a framework for care of patients with heart failure, identify the etiology, pathophysiology, and clinical manifestations of pulmonary edema, describe the medical and nursing management of patients with complications from heart disease. Heart failure is a condition in which something prevents the ventricles from either sufficiently filling or ejecting blood. If the insufficiency is in the filling, it is referred to as diastolic failure. If the insufficiency is in the contraction itself, it is referred to as systolic failure. Heart failure is the most common reason for hospitalizations of people over the age of 65. It is the second most common reason for visits to a physician's office. Prevention as well as early interventions are the key to reducing those hospitalizations. The type of heart failure is determined by an echocardiogram. The ejection fraction is assessed during the echo. Normal ejection fraction, or EF, is 55 to 65%. Patients with systolic heart failure will have decreased EF. Systolic heart failure results in decreased blood ejected from the ventricle. The baroreceptors in the aortic and carotid vessels will sense the decreased blood flow and stimulate the sympathetic nervous system to release catecholamines in an attempt to increase the heart rate and contractility of the muscles. The stimulation of the sympathetic nervous system will cause vasoconstriction, which decreases renal perfusion. This decrease will cause the release of renin by the kidneys. The renin is converted to angiotensinogen, which is then converted to angiotensin 1, which goes to the lungs, and then it's converted from angiotensin 1 to angiotensin 2. Angiotensin 2 is a vasoconstrictor, and it will cause an increase in the blood pressure as well as the afterload of the heart. It also stimulates the release of aldosterone, which results in fluid and sodium retention. And this is what will cause the fluid overload symptoms that you see in heart failure. The increased workload on the heart will trigger a compensatory mechanism, releasing natriuretic peptides, which will promote vasodilation, as well as diuresis in an attempt to reduce the workload. Unfortunately, this attempt is not successful as the other mechanisms will override or win out from the peptides. The cycle will continue if no intervention is done to break the cycle, and this can lead to stiffening of the ventricle, which further decreases the cardiac output. As far as patients diagnosed, a third have systolic dysfunction, a third will have diastolic dysfunction, and then a third will have both. So you can actually see both systolic and diastolic. This is just a visual, if you're a visual person, a visual way to remember systolic versus diastolic. As far as clinical manifestations, you have right-sided heart failure or left-sided heart failure, and you have bibasilar fine crackles, and that's a sign of alveolar fluid, which is a left ventricular heart fluid or heart failure. Jugular vein distension, right upper quadrant pain due to hepatomegaly, and dependent edema are caused by right-sided heart failure. Left-sided is usually lung, and then right-sided is usually peripheral or systemic. As far as gerontologic considerations, when you're giving diuretics to gerontologic population or the older adults, you have to be careful because some of the diuretics can cause kidney damage. and that's because of the increased strain on the kidneys from the diuretics. Also, the increased volume of urine that is produced from diuretics in older men can lead to bladder distension because they might not be able to, due to an enlarged prostate, they might not be able to empty their bladder completely. The distension can lead to bladder spasms. It can lead to backflow of urine back into the ureters and the kidneys, causing nephritis. As far as the assessment goes, you're going to do a focal assessment, look for mental status change. You're going to listen to the lungs. Do you notice any crackles or wheezes? As far as heart sounds, do you hear S3 or S4? Fluid status, look at I and O, see if there's any signs of fluid overload, so jugular vein distension, edema, whether it's a dependent edema or ascites. They'll get a daily weight as well as assessing responses to medications that they're on. You're also going to assess for signs and symptoms of pulmonary edema. As far as medications, they can be on ACE inhibitors, they can be on beta blockers, hydralazine, or IMDR, and those are alternative to ACE inhibitors. Angiotensin II blockers can be prescribed as well instead of the ACE inhibitors. Beta blockers would be in addition to ACE. Diuretics will help to pull that fluid off and decrease fluid volume. They can be on digoxin. It improves the contraction, but you need to watch for dig toxicity. And then you can also give IV medication if you need to, if they're in acute heart failure. You'll want to do frequent rest periods and alternate rest with activity. They do need to be active, so they need to kind of plan out when they're going to be active and when they're going to rest. If they are having an exacerbation, you want to encourage rest, so you're not putting extra strain on the heart. Okay. Avoid extreme temperatures, and try and sleep with the head of bed at least somewhat elevated or extra pillows. And then if they do have edema, then they can put their feet up, or you want to watch any type of compression stockings though, because if the body is trying to displace fluid and it can't displace it into the most dependent areas, then it will displace it into the lungs and then they'll have pulmonary complications. Watch for fluid volume excess. We already talked about that. Diuretic therapy, they do not need to take the diuretics in the evening because it's going to make them go to the bathroom a lot. If they do have orders for once a day, it should be in the morning. If they have orders for twice a day, then you can do morning and afternoon. You don't want your patients getting up in the middle of the night to go to the bathroom though. Then they won't be tired, or they'll be tired all the time and they'll have increased fatigue, which will actually make it worse for their heart. They will need to have sodium restriction, 2 grams sodium restricted diet, or no salt diet, depending on what the physician orders. So you're going to need to educate them on that. They might be on fluid restriction. If they are, then you need to talk to them about how they can split up their fluids throughout the day, as well as how to measure their fluid intake and what is a fluid. So what do they need to measure? What do they not need to measure? They need to monitor stress, talk about positive coping mechanisms, talk to them about how they can prevent infection, when to contact their health care provider. They need to do regular follow-ups. They need to do daily weights, and it needs to be the same time every day with the same amount of clothes on. So I usually tell my patients, keep the scale on your bathroom when you go in the morning. Take your clothes off, because normally you get out of your night clothes and into your day clothes. Once you're naked, jump on that scale. Heart failure is chronic, it is progressive, and so you do need to talk to them about getting things set, getting things in order, getting a power of attorney, both medical and durable, getting a living will, and then getting a will set up for their estate and whatnot, and making sure that their wishes are known so that the family and the doctor can follow through. You can talk to them about palliative care and hospice, and it's better to do this when they have time to think about it rather than when they need to make a pretty quick decision. That way they're not making the decision when they're stressed. As far as pulmonary edema goes, the left ventricle is unable to sufficiently move the blood, which results in the blood backing up into the pulmonary veins. In a way to compensate, the capillaries in the lungs will release fluid into the interstitial spaces and the alveoli. The edema will reduce the ability for gas exchange to occur, leading to hypoxemia. The brain will become deprived of oxygen, causing the patient to become confused and anxious. If you do not catch it, then the patient will become unconscious and they can go into respiratory failure. If you listen to their lungs, you will hear a lot of congestion, crackles, rails. Whenever they are breathing in and out, you might actually hear it. They'll have increased sputum production. It can be frothy. It can also be blood tinged. They will be pale or cyanotic. Their pulse will be rapid and weak because they're not able to get the oxygen that they need. They can have cool, clammy skin, be diaphoretic as well. Prevention of pulmonary edema is the key, and pulmonary edema can come on pretty quickly, like within minutes. So you do really need to watch for it. As nurses, we need to be focused on a pulmonary assessment, monitor the response to heart failure treatments, watch for early signs of pulmonary congestion. ABGs can be monitored as well. Electrolytes can be monitored. The BUN, creatinine can be monitored for kidney function. Chest x-ray will show evidence of pulmonary edema as well, but you might be a little bit late if you are trying to get a chest x-ray. The patient will be placed on a non-rebreather initially, and then they will be weaned down as appropriate. Diuretics can help get rid of the fluid. Vasodilators can help somewhat with the symptoms as well. You'll want to position the patient to reduce venous return to the heart. So offer support, which means they're going to be upright with the legs dangling. So they're going to be sitting on the side of the bed. Make sure that they're able to do that. You don't want them falling out of the bed because then they'll have further injuries. Offer support and reassurance. The patient is going to be extremely anxious because they're having trouble breathing. Make sure that when you do talk to them that you have simple, concise information and instructions. So keep things really short and sweet. Keep your tone low, talk slowly. If you're talking quickly and you seem like you're excited, then they'll get easily excitable. If you speak softly, this gives them something that they have to focus on, and so they're not focusing on their breathing as much as they're focusing on listening to what you're saying, but don't talk so low that they can't even hear or understand you. You can also try diaphragmatic breathing. That helps sometimes as well. Monitor their blood pressure. If you're giving them vasodilators, they need strict intake and output, especially with diuretics. And then you'll do daily weights. The patient needs to be on continuous ECG monitoring as well to make sure that there's no dysrhythmia or arrhythmias. Cardiogenic shock. Refer back to chapter 14 if you have to, if you don't remember this, but it is covered in the shock chapter. It can occur following an MI, especially if there's a large area of the myocardium that becomes ischemic and necrotic. It can also occur as a result of end-stage heart failure, cardiac tamponade, pulmonary embolism, cardiomyopathy, or certain dysrhythmias. Thromboembolism, atrial fibrillation can cause an embolism or thrombus. Decreased mobility, atherosclerosis, smoking, those are just some of the causes. The clot will break off and travel to the pulmonary artery, and then the patient can suffer from a PE. PEs are blood clots in the lungs, and the blood clot reduces or completely obstructs the blood flow. Treatment is generally anticoagulation therapy. They can also have clots that develop elsewhere in the body. If they do, you want to make sure that they do not travel to the heart, lungs, or brain, because then they'll have an MI, a stroke, or symptoms of a PE. A patient who does have a PE, they're going to have severe shortness of breath, pleuritic chest pain, they'll be tachypnic, they will have a cough. Pericardial effusion, that's the accumulation of fluid in the pericardial sac. The increase in the pericardial fluid raises the pressure within the pericardial sac and also compresses the heart. This causes elevated pressure in all 4 chambers of the heart and decreases venous return due to atrial compression and the inability of the ventricles to distend and fill adequately. A treatment of this is a pericardiocentesis, so that they go in and actually remove some of that fluid. And then you have cardiac tamponade. In here, you have restriction of heart function because of generally pericardial effusion. And the patient will have a falling systolic blood pressure. Their pulse pressure will become narrow. They'll have rising venous pressure, and then you'll be able to hear distant heart sounds. And treatment for that is going to be this window. They can have a pericardiocentesis to get rid of the fluid as well. But the pericardiotomy is usually the cardiac window or pericardial window. You might hear that as well. And that's whenever a portion of the pericardium is excised and the fluid can drain that way. If you have a patient who's in sudden cardiac death or cardiac arrest, then you want to do cardiopulmonary resuscitation, defibrillation if it calls for. Start with making sure they have a patent airway, they're breathing adequately, circulation, and then defibrillation if they're in VTAC or VFib.